Hi everyone, my name is Dan. I'm a mental health pharmacist, and today I will be doing a video to help prepare you for the NAPLEX exam, where today we will focus on psychiatry. So there's 5 major sections to the presentation today. The first section will talk about depression, second section anxiety disorders, then schizophrenia, bipolar disorders, and finally we'll end with other psychiatric conditions. So let's start into depression. So I'm going to do my best to highlight the key points that you need to know, and then we'll go over a few practice questions. So some key points for depression is that medications are equally effective. So we're not picking SSRIs over TCAs because SSRIs are more effective. We pick these options based on side effect profile, not efficacy. A good thing to know about antidepressants is all of them have boxed warnings for suicidality in young adults, so this is an important counseling point that could be a question on your NAPLEX. The first-line options for major depressive disorder include SSRIs, SNRIs, bupropion, mirtazapine, 4-deoxetine. Some guidelines have vilazodone and trazodone. So remember, we're selecting this agent based on your goals, what symptoms the patient's having, what side effects you're trying to avoid, not necessarily efficacy. So we'll start with the SSRIs. These are definitely medications you'll need to know for the NAPLEX. Extremely popular, common medications, so I would recommend knowing the brand and generic for these. I lump them together with citalopram and escitalopram because they're similar. Brand names Celexa and Lexapro. Fluoxetine and fluvoxamine sound similar, Prozac and Luvox, and then sertraline and paroxetine, Zoloft and Paxil. So what is unique about each? What distinguishes the SSRIs from each other? First, for citalopram, brand name Celexa, think cardiac. So citalopram causes dose-dependent QTc prolongation. The dose used to be higher than it is today, but now we cap it at 40. So if the patient has any cardiac condition, long QT syndrome, bradycardia, hypokalemia, anything that could affect the heart, and this is in a NAPLEX question, they're probably telling you to avoid citalopram. So when you think citalopram, think cardiac. The thing to know about fluoxetine is its long half-life. So if you stop other SSRIs suddenly, you can get discontinuation syndrome, which is like a withdrawal from SSRIs. Fluoxetine, this doesn't really happen because of its really long half-life. Its active metabolite has a half-life of a very long time, effectively self-tapers. Next is fluvoxamine. The unique component of fluvoxamine is that it's only approved in the USA for OCD. Finally, paroxetine has a short half-life, so it has the most discontinuation syndrome. You might note that I don't have escitalopram or sertraline on this slide. They're very good medications, very commonly used, but they don't really have something that's super unique or different about them to highlight on this slide. Finally, I forgot to mention fluoxetine is also available in combination with olanzapine. The brand name is Symbyax for treatment-resistant depression. There are very few medications with that indication of treatment-resistant depression. Now let's go into the SNRIs. There are 4 of these. 2 of these are extremely common medications in venlafaxine and duloxetine. Desvenlafaxine sometimes used, levomilnacipran is not that commonly used. So knowing the brands of the most commonly used ones are important. So what's unique about SNRIs? So they're no longer selective to serotonin like the SSRIs. We now block the reuptake of norepinephrine. So doing this increases blood pressure. So if you have a patient with depression and uncontrolled blood pressure, an SNRI probably isn't the best option. But SNRIs, the norepinephrine component, helps with pain. So if you have a patient with depression and nerve pain, SNRI might be a really good option. Things to know about venlafaxine is it has lots of FDA approvals in psychiatry. So yes, MDD, but also generalized anxiety disorder, social anxiety disorder, panic disorder, so on. And it does cause that elevation in blood pressure. Next is duloxetine. So it does have psychiatric approvals, but it also has many non-psychiatric approvals. So diabetic peripheral neuropathy, fibromyalgia, chronic musculoskeletal pain. So you might get a question on the NAPLEX without even a patient with a psychiatric condition where duloxetine is a good answer because it is approved for all these pain conditions. Next we have miscellaneous antidepressants. So these are kind of all their own mechanisms, they're all a little different, but rather than having a bunch of different classes of antidepressants, these are kind of lumped together. Some call them other antidepressants or miscellaneous antidepressants. Bupropion, brand name Wellbutrin, is definitely a good medication to know about. The NAPLEX commonly asks about this. Next is mirtazapine, brand name Remeron. We have some relatively newer medications with vilazodone and vortioxetine, and then trazodone is commonly used as well. So what do we need to know about these medications? First, for bupropion, lots of things. This is not serotonergic, so it does not really have serotonin syndrome by itself, and it doesn't cause really much sexual dysfunction because it's not serotonergic. So its mechanism is a norepinephrine and dopamine reuptake inhibitor. So if you're familiar with how stimulant medications work, they work similarly to that. So these are activating medications that are used off-label for ADHD. A big approval for bupropion is its use in smoking cessation. So that's a good fact to know about this medication. Next is when not to use it. So patients with seizures or patients with eating disorders. So seizures is a side effect that can occur, and this was especially seen in underweight patients, so that's why they included eating disorders. This is available in a relatively newer product in combination with dextromethorphan for depression. The brand name is Auvelity. So dextromethorphan is an NMDA receptor antagonist. So you can think of ketamine, S-ketamine, which are used for depression, are NMDA antagonists. And then bupropion does have its own antidepressant mechanism, but it's also a CYP2D6 inhibitor, so it prolongs the plasma levels of dextromethorphan. So lots of things to remember with bupropion. The biggest stuff is probably that it's not serotonergic and its use in smoking cessation. For mirtazapine, this is an alpha-2 antagonist, basically, that increases the release of serotonin and norepinephrine. This is taken at night because it's sedating and causes a lot of weight gain. One of the themes in psychiatry that you'll see is that medications that are sedating often also cause weight gain, and this is true with mirtazapine. Although it is serotonergic, it's indirectly serotonergic, so there is less sexual dysfunction here. Vilazodone and vortioxetine, some people lump them in with the SSRIs, but they're a little more complicated, a little newer, a little different. So vilazodone is an SSRI plus a 5-HT1A partial agonist. So if you're familiar with buspirone, brand name Buspar, that's a 5-HT1A partial agonist. Vortioxetine is a pretty complicated SSRI-like medication, but it does have some pro-cognitive benefits, and it is first line in the Canadian guidelines, and once it becomes less expensive in the US, it might be first line here as well. Next is trazodone. Trazodone is serotonergic, but different than SSRIs, and is used super commonly, but it's more commonly used for sleep than it is for depression these days, so it is sedating. Next, we have the tricyclic antidepressants. So there are many more tricyclic antidepressants than what I have listed here, but these are the most common. The ones that you're most likely, if you're going to get a question on a TCA, it will be one of these. So we have amitriptyline, nortriptyline, doxepin, clomipramine. So what do you need to know about TCAs? TCAs are more complicated SNRIs. So they do have that SNRI mechanism, but they're clumsier, they're messier. So there's a phrase, ham-handed. It means like a clumsy attempt at something. So I think of TCAs as ham-handed SNRIs, with ham meaning they block histamine, alpha, and muscarinic receptors. So this gives you a lot of the side effects of TCAs as well. So by blocking histamine, they're sedating, can cause weight gain. By blocking alpha, blood pressure drops, falls, orthostasis. By blocking muscarinic receptors, they're anticholinergic, so all of the anticholinergic side effects. And these do have effects on norepinephrine, so they are used for pain conditions, just like SNRIs. So migraine prophylaxis, chronic pain, nerve pain, so on. The big issue with TCAs are not efficacy, rather it's that they're fatal in overdose. One thing to remember about the overdose treatment is it's with sodium bicarbonate. So I remember this by a car crushes a tricycle. So sodium bicarbonate treats tricyclic overdose. What is unique about the TCAs? Amitriptyline is a top 100 drug, even though it's not commonly used for depression, due to its other uses, migraine prophylaxis, nerve pain, things like that. Doxepin is FDA approved in a smaller formulation, a smaller dose, for sleep, and it is available as a higher dose as well. And then clomipramine is used for OCD quite commonly. Next is the MAOIs. These aren't very commonly used in depression. You might get a question about them, but you may not as well. Selegiline, the MSM patch, is probably the most common one that you would get a question on. These are used in Parkinson's as well. What do you need to know about MAOIs? Their mechanisms. So their monoamine oxidase is the enzyme that breaks down monoamines. So if you inhibit this enzyme, you increase monoamines. Your monoamines being serotonin, norepinephrine, and dopamine. The big thing with MAOIs is to avoid tyramine-containing foods. So cheeses, wine, beers, fermented foods, all of these things can cause a hypertensive crisis if you take them with an MAOI. So selegiline I have highlighted here, used for Parkinson's, and the patch may limit food reactions at lower doses. Some additional medications have some unique FDA approvals. We have esketamine, Spravato, and zuranolone, Zurzuvae. So esketamine is an NMDA antagonist. We mentioned before with dextromethorphan that these mechanisms can be used in depression. This is a controlled substance and it has a REMS program. So the NAPLEX likes to ask about medications with these specific REMS programs. This is available as a nasal spray only. It has unique FDA approvals, so it's treatment-resistant depression, not just standard depression. So we mentioned one other med that has that approval. Then this is also approved for depression with acute suicidal ideation, so good to know as well. Next we have zuranolone. So the biggest thing to know about zuranolone is its FDA approval, its indication. And this is for postpartum depression specifically. Its mechanism is quite interesting. It's a positive allosteric modulator of GABA A receptors. So, for example, benzodiazepines are GABA A agonists. They make you sleepy, they make you sedated. So this has a box warning not to drive at least 12 hours after taking, and this is also controlled. There used to be an IV medication in this class called brexanolone available. It's no longer available. Additional medications are available as adjuncts. So you can see we have lots of antipsychotic medications that can be used and are approved as adjuncts to SSRIs or SNRIs. So aripiprazole, brexpiprazole, cariprazine, quetiapine. Then mirtazapine and bupropion can be used by themselves in their first line for depression, but they can be also used as adjuncts to SSRIs, SNRIs. And then lithium, mood stabilizer, commonly used in bipolar, can also help with depression. Serotonin syndrome is a question that the NAPLEX sometimes likes to ask about. So generally this occurs when people are on multiple serotonergic meds, though in theory it is possible on a single medication as well. The symptoms are broad, not super specific, but tremor, myoclonic movements, diaphoresis, fever, shivering, all sorts of things can happen. But the causal agents is normally what they would ask you about. So it's not just the serotonergic meds that come to your mind, it's also things like opioids, lithium, St. John's wort, carbamazepine, linezolid, so an antibiotic, methylene blue. All of these other things can increase serotonin and contribute to serotonin syndrome. Like I mentioned, these typically require multiple serotonergic meds to occur, and then there's specific facts with MAOIs in regards to serotonin syndrome, when you can start MAOIs, and so on. So in summary for depression, first-line treatment options are therapy, but also many medications based on side effect profile and other factors. So SSRIs, SNRIs, mirtazapine, bupropion, vortioxetine, generally not things like TCAs, MAOIs. They take time for their full effect, so at least 4 weeks, probably even longer than that. The box warning is good to know about, and serotonin syndrome is good to know about. So now let's go over some review questions. So a patient with depression is interested in starting a medication. He is currently taking losartan 50 milligrams once daily for hypertension and has congenital long QT syndrome. Which antidepressant medication should you recommend? So feel free to pause, think about it, come up with your answer. But the best answer is Paxil. So remember, with citalopram, Celexa, think C, cardiac. So you don't want to use it in this patient with the congenital long QT syndrome. Then the patient, even though it doesn't mention uncontrolled hypertension, they do have hypertension, so you would probably lean away from the SNRIs. So Effexor and Cymbalta you can eliminate, Paxil being the best answer. What is the mechanism of action of Lexapro? Feel free to pause. And this is, you have to know the brand in generic. This is escitalopram, which is a SSRI. Next, a patient with diabetes and uncontrolled diabetic peripheral neuropathy presents to the mental health clinic and is diagnosed with depression. Which medication should you recommend? So feel free to pause, think about it. The best answer is duloxetine. So this is a first-line medication for depression. It will also help with the diabetic peripheral neuropathy. What patient population is warned of increased suicidality when starting antidepressant medications? And the answer is adolescents and young adults are the patients that have that boxed warning. Patient with depression has trouble concentrating and has bulimia nervosa. Which antidepressant medication should you recommend? And the answer is fluoxetine, which is approved for bulimia nervosa and helps with depression. The trick here is you might want to select bupropion for the trouble concentrating, but that's not a good medication if the patient has bulimia nervosa. So fluoxetine is the best. Which medication used as monotherapy would be least likely to cause serotonin syndrome? So as monotherapy, it's bupropion because it's not serotonergic. But remember, this is a CYP2D6 inhibitor, so when used with other serotonergic meds, it can contribute to serotonin syndrome. 72-year-old patient with depression is prescribed selegiline patch. During the counseling session, the pharmacist emphasizes the need for dietary modifications while on this medication. Which of the following counseling points is needed? So when it comes to MAOIs, the patient should avoid foods rich in tyramine to prevent a hypertensive crisis. 30-year-old female has been taking escitalopram 10 for 4 weeks. Her depression symptoms have decreased from severe to moderately depressed. What is the recommended next step in treatment? So the best answer here is actually C, increase escitalopram to 20 milligrams. So you want to maximize the dose before you start adding adjuncts. So the patient clearly has some efficacy with the escitalopram because they went from severe to moderately depressed, but the dose hasn't been maximized. Which of the following medications is FDA approved for treatment-resistant depression? And the answer is esketamine. Patient is prescribed an SSRI for the treatment of major depressive disorder. Which of the following are potential risks or concerns when using SSRIs? Select all that apply. And the answers are serotonin syndrome, suicidal thoughts, especially in young adults, and discontinuation syndrome. Okay, let's continue on and go into anxiety disorders. So the key points with anxiety disorders are that there are many different anxiety disorders. So generalized anxiety disorder is most commonly thought of, but there are a bunch of other ones. Generally, you're going to use SSRIs first line. You can use SNRIs as well. Since we already talked about the SSRIs and SNRIs, I'm going to focus on other medications for anxiety. So additional medications we use in anxiety are benzodiazepines, buspirone, and hydroxyzine. So benzodiazepines are very commonly used medications, even outside of anxiety. They're used for many other things. So these are common medications that you will get questions on the NAPLEX about. So knowing these are just a few of them, brands and generics are important. And then your other meds are buspirone, Buspar, and hydroxyzine, Atarax, or Vistaril. So what is unique about these? Well, for benzos, they are GABA-A agonists. So GABA is the primary inhibitory neurotransmitter. So if you agonize this, if you make it stronger, you'll make people sleepy, which is what benzos do. Some are long-acting and have active metabolites. So you can think of diazepam, chlordiazepoxide have days in the name. So they last for days is how you can remember that they have long half-lives. Though many of the other benzodiazepines have active metabolites as well. These have many uses outside of just anxiety. So seizures, alcohol withdrawal, procedural sedation, agitation, all sorts of things, aggression. They're used for many things. The ones that don't have active metabolites and they're metabolized in the liver through glucuronidation, which is different than the other ones, are lorazepam, oxazepam, and temazepam. So some people learn this as the lot drugs, other people learn this as OTL, outside the liver. They're still metabolized in the liver, but it's not CYP-mediated processes, it's glucuronidation. So however you remember it's okay, but these are the benzos preferred in older adults or those with hepatic dysfunction. You have to taper off benzos after extended use. These can be fatal in withdrawal. They're very similar to alcohol in that they're used for alcohol withdrawal, and alcohol can be fatal in withdrawal. Next for buspirone, this is serotonergic, so it's a 5-HT1A partial agonist. Serotonergic meds generally don't work quickly, so this is not a PRN. You have to take this for a while to get the full effects. Hydroxyzine is an antihistamine that is a PRN, so it's really the only commonly used PRN that's not controlled in anxiety. So it's a good medication to know about. Next, some other anxiety-related disorders. I didn't want to make a whole topic on these, but PTSD, so you treat with therapy, especially trauma-focused therapy, SSRI, SNRI. A good trick to remember which SSRIs are FDA approved for PTSD are, there's no SSRI that starts with T or D, but there is that starts with P and S in PTSD, and it's paroxetine and sertraline. Next, OCD, you use exposure-based therapy as well, SSRIs, and clomipramine is a good third-line option. It's stronger, but has more side effects, more issues. So clomipramine, the TCA, this is a good use for that. Next, some questions for anxiety. So a 38-year-old patient is prescribed lorazepam 1 mg 3 times a day for the treatment of anxiety. The pharmacist is counseling the patient on the proper use and potential risks. Which of the following counseling points is needed? So this medication may cause drowsiness. Avoid driving or operating heavy machinery until you know how it affects you. Next question. 78-year-old female presents after a recent fall, has been taking benzos for over a year. The team would like to initiate a benzo taper. Which medication would you recommend to prevent withdrawal? So lorazepam is one of the lot medications preferred in older adults. That would be the best choice based on the information provided. Which of the following meds are used in the treatment of generalized anxiety disorder? Select all that apply. So clonazepam, benzos can be used, venlafaxine, SNRIs can be used, hydroxyzine can be used. Aripiprazole and perfenazine are antipsychotics, generally not used. Okay, let's go into the third section, which is on schizophrenia. Some key points about these medications is that the medications are equally effective except for clozapine. So clozapine is the most effective but has lots of side effects and lots of monitoring, so we don't use that first line. First line options are generally second gen antipsychotics, but many guidelines still have first gen antipsychotics as first line options as well. Long acting injectables, LAIs, can be used first line, but you have to determine oral tolerability and efficacy first. In general, the first gens have more EPS side effects, less metabolic side effects, and second gens have more metabolic side effects and less EPS, though there is overlap. Of note, all antipsychotics have a box warning for increased mortality and dementia-related psychosis, so a good box warning to know about. There are many first-generation options, there are many second-generation options that we'll go through in more detail in a few slides. So here are the first-gen antipsychotics. There are many more than this, but if you're going to get asked a question, it will probably be about one of these. Haloperidol, Haldol is extremely commonly used. Flufenazine is as well. So these both have long-acting injectable options. They both have short-acting IMs. Then you have like loxapine, which has an inhalation version, and then chlorpromazine, which is a low-potency agent. So what is unique about the first gens, or what do we need to know about these? Well, their mechanism is they're D2 blockers, dopamine blockers. Side effects are related to potency. So highly potent first gens have more EPS, less anticholinergic side effects. Lower potent first gens have less EPS and more anticholinergic side effects. So how do you know if a first gen is high or low potency? Well, it's literal. So a highly potent first gen needs a low amount of milligrams to get the effects. So for example, if you see the dosing in 1 digit, so Haldol 5, flufenazine 2, you know that's highly potent, so it's going to cause a lot of EPS. Whereas something that's low potency, like chlorpromazine, the dosing is 3 digits, so less EPS, more anticholinergic side effects. I mentioned haloperidol and flufenazine. These are both high potency agents, but they're available as LAIs and short-acting IMs, so commonly used. And then loxapine as a unique formulation, available as an inhalation for the treatment of agitation. For the second gens, I have these informally broken down into kind of like subclasses. So you have the penes, the one that end in penes, the dones end in done, and then the partial dopamine agonists. So what do you need to know about the penes? In general, the penes are sedating and cause a lot of metabolic issues, a lot of weight gain, and have less EPS. Cenopene's has a little bit of a difference in that it doesn't cause much weight gain. Some things to know about clozapine is it has a REMS program, It has it's third line. It's used for treatment-resistant schizophrenia, but it has a lot of monitoring for agranulocytosis. You have to get an absolute neutrophil count when you start every week. Next is olanzapine, really sedating, really metabolic-y. So it causes a lot of weight gain. A newer formulation in combination with samidorphan was approved that causes a little less weight gain. Quetiapine has many approvals, sedating, you take it at night, weight gain, not much EPS, so it falls into the pattern. And then the thing to know about asenapine is its routes. So it's available as a patch and a sublingual. It's not given as a typical oral medication due to extensive first-pass metabolism. For the dones, they do have a little bit of sedation sometimes and a little bit of EPS or a little bit of metabolic issues, but they have more EPS than the penes do. Risperidone's a good medication to know, commonly used. It has lots of formulations. Its active metabolite paliperidone is commonly used as well. They're available as long-acting injections and so on. Then for ziprasidone and lorazepam, these must be taken with food. So a way to remember that is you put food in a Ziploc bag. Ziprasidone, lorazepam, both required to be taken with food. Next is the partial dopamine agonists. So these mechanisms are different for these medications, aripiprazole, brexpiprazole, cariprazine. So they're not D2 blockers and 5-HT2A blockers like the other second gens. They're D2 partial agonists. So because they're not blocking dopamine strongly, they generally don't cause much EPS. Some of them cause a little bit of akathisia, but generally the other types of EPS aren't commonly seen. Additionally, they don't cause much sedation, weight gain, so they have a decent side effect profile. And they have many uses. This is why aripiprazole is the top-selling psych drug of all time. Some additional options, lumateperone, Caplyta is another medication. It blocks 5-HT2A much stronger than D2. And then we have a newer medication, xanomeline and trospium, which is Cobenfy, which does not work on dopamine, it works on muscarinic receptors. So we mentioned EPS, so this is a grouping of side effects that can occur when you block dopamine strongly. There are four major types of EPS. We have acute dystonia, so imagine someone in the ED gets a bunch of Haldol and they get really stiff. You treat this with anticholinergics like benztropine or Benadryl. Akathisia is this internal restlessness that can happen. So the patients that are pacing on the unit, they can't sit still, they have ants in their pants, treat with propranolol. Next is pseudo-Parkinsonism. So remember, you treat Parkinson's with dopamine. So if you block dopamine, you can cause Parkinson's. It's a fake Parkinson's, so it's called pseudo-Parkinson's, but has the same symptoms: tremor, rigidity, akinesia, postural instability. Also treat this with anticholinergics. Finally, we have tardive dyskinesia, which can be permanent. That's why this is a really serious type of EPS. You generally start by switching medications to something that blocks dopamine less strongly, but there are medications, they're called VMAT2 inhibitors like valbenazine or deutetrabenazine that can help treat tardive dyskinesia. Next is neuroleptic malignant syndrome. So like how antidepressants have serotonin syndrome as the big side effect, neuroleptic malignant syndrome is the big side effect of antipsychotic medications. So this can be fatal. It's a really serious reaction. It can cause hyperthermia, confusion, stupor, all sorts of stuff. You treat it generally with dantrolene. Sometimes you use benzos, and you DC anything that blocks dopamine, not just antipsychotics. So in summary, there's lots of medications that can treat schizophrenia, first gen and second gens. Generally, efficacy is similar. We generally start with second gens these days, and clozapine is your third line option, and it's approved for treatment-resistant schizophrenia. Box warning of the increased mortality and dementia-related psychosis is good to know, and then EPS and NMS are good things to know about. LAIs, long-acting injections, are sometimes asked about, so it's good to know which ones have those formulations. So first gen options are Haldol and flufenazine, and then aripiprazole, paliperidone, risperidone are common. Olanzapine has an LAI. There's some that have LAIs. So for the questions, a 76-year-old male with Alzheimer's disease has been physically aggressive, was prescribed olanzapine 5 mg at night. What box medication warning should be considered in the patient? And it's the increased risk of mortality. Patient tried and failed 2 atypical antipsychotics. Which of the following medications would be the next best treatment option? And it is clozapine. Patient treated with haloperidol 5 milligrams 3 times in the ED develops acute dystonia. How can this be treated? And that is benztropine. 22-year-old female has been diagnosed with schizophrenia, has never taken an antipsychotic before. She states she cannot swallow pills or tablets but would like to start treatment. Which of the following would you recommend? And the answer is asenapine, which is sublingual or a patch. The LAIs you wouldn't be able to do because you have to determine oral tolerability and efficacy first. So if she's never taken them before, you can't start with the LAIs. What monitoring is required for patients taking clozapine? And it's absolute neutrophil count. 28-year-old prescribed lorazepam 40 for the treatment of schizophrenia. The pharmacist is counseling the patient on how to take the medication. Which of the following counseling points is needed? So take this medication with food to aid in absorption. So remember, Ziploc bag, ziprasidone, lorazepam. Which of the following is an important counseling point for a patient taking aripiprazole? So aripiprazole is a dopamine partial agonist, so it has a low risk of EPS compared to most other antipsychotics. Which of the following antipsychotic medications are available in a long-acting injectable formulation? Select all that apply. So aripiprazole, risperidone, paliperidone are LAI options. So next, let's go into bipolar. So the key points with bipolar is that bipolar disorders are treated with mood stabilizers. With the exception of lithium, mood stabilizers are anticonvulsants, so seizure meds. So you'll have seen these medications before. Different medications are selected based on if you're treating bipolar mania or bipolar depression, which we'll go over on the next slides. Medications like carbamazepine and oxcarbazepine are typically not first line, and then antidepressant medications are sometimes used in bipolar depression, but they're not first or second line options. They're used further down the line. So when I think of treating bipolar, I think of, am I treating bipolar mania or bipolar depression? So the options for each of these that are first line are generally 2 mood stabilizers for each, and then antipsychotics. So for bipolar mania, your 2 mood stabilizers are lithium or valproic acid products. For bipolar depression, it's the 2 L's, lithium or lamotrigine. Then for antipsychotics, for bipolar mania, it's pretty much any of the antipsychotics will help with mania, though we typically use second-gen options. For bipolar depression, it is not every antipsychotic. There are specific ones that we use. So you can remember this as your mood swings in bipolar depression like a clock. Clock being spelled CLLOQ, which is cariprazine, lumateperone, lorazepam, olanzapine with fluoxetine, and quetiapine. Your mood stabilizers can be seen here, and remember, with the exception of lithium, all these other medications are anticonvulsant medications. So what is unique about lithium? Well, we do check levels. This has a narrow therapeutic index, so the level range is typically 0.6 to 1.2. This is teratogenetic in the first trimester due to heart abnormalities. Once the heart is formed, you can use lithium in the other trimesters. Lithium can be hard on your kidneys. You want to monitor kidney function. And lithium interacts with common medications, NSAIDs, ACE ARBs, diuretics, especially thiazide diuretics. So knowing those interactions can be helpful for the NAPLEX. Next, lithium has linear pharmacokinetics. So if you double the dose, you double the level, which could be good if you have a calculation question. Valproate products, there's a lot that fall under that. So valproic acid, valproate, depakine, depakote, divalproex, they're all in that kind of family. Therapeutic level is 50 to 125, highly teratogenic. You try not to use this in pregnancy. It's very rarely done with lots of folate, but you don't use it in pregnancy. Lithium's hard on your kidneys, but depakote's hard on your liver, so you monitor that. And there's 3 boxed warnings. So VPA, very problematic agent. It's vital organs, liver, hepatotoxicity, pancreatitis is a boxed warning, and then A, abnormal babies, teratogenicity. So hepatotoxicity, pancreatitis, teratogenicity are the boxed warnings. Next is lamotrigine. The big thing to know about lamotrigine is it requires a very strict titration. You have to go really slowly up on the dose, and this is due to skin rashes that can occur. Stevens-Johnson syndrome, toxic epidermal necrolysis can happen. So some ways to remember that is lamotrigine, tricky rash, or go slow or skin will blow. So think of lamotrigine, think of the titration and the skin side effects. Next is carbamazepine. This does have a level 4 to 12. In those of Asian descent, you do a genetic test for HLA-B1502 because they're at higher risks of getting SJS or TENS if they have that gene. Next, it is an enzyme inducer, so the NAPLEX loves to ask about inducers or inhibitors, but this is unique in that it's an autoinducer. Autoinducer meaning it induces its own metabolism. So when you think of carbamazepine, think autoinducer. Which of the medications would be first-line option in a patient treated with bipolar depression? So the best answer is lithium. Which of the following medications would interact with lithium? The best answer is meloxicam, which is an NSAID. What is the recommended serum level of lithium? The range would be 0.6 to 1.2. Patient taking lithium 1200 at night has a lithium level of 1.4. The doctor would like a level of 1.0. What dose of lithium would you recommend? So remember, it has linear pharmacokinetics, so you could cross-multiply to find the answer, 900. What trimester of pregnancy is valproate not recommended? So it's every trimester. Remember, lithium's just the first trimester, valproate is every trimester. Which mood stabilizer must be titrated slowly to decrease the risk of Stevens-Johnson syndrome? And that is lamotrigine. 40-year-old patient with bipolar disorder is started on carbamazepine. The patient is taking oral contraceptives. Which of the following statements regarding the use of carbamazepine and oral contraceptives is most accurate? So remember, carbamazepine is an inducer, so carbamazepine may decrease the effectiveness of oral contraceptives. Which of the following has an FDA approval for bipolar depression? Select all that apply. So this is that clock mnemonic. So cariprazine, Latuda, which is lorazepam, and Seroquel, which is quetiapine, all have that approval. Which of the following are box warnings for divalproex? So we have hepatotoxicity, pancreatitis, and teratogenicity. All right, let's go into other psychiatric conditions. So we have ADHD, attention deficit hyperactivity disorder. Stimulants are typically first line here. These work by being norepinephrine and dopamine reuptake inhibitors, so remember bupropion. And amphetamines also stimulate the release of norepinephrine and dopamine. These are controlled substances, and when you think of stimulants, think of the two major families, the methylphenidate family and the amphetamine family. These are stimulants, so they can cause insomnia, and they also cause appetite suppression. There are non-controlled, non-stimulant options for ADHD as well. Some examples would be norepinephrine reuptake inhibitors like atomoxetine or viloxazine, and these do have that box warning that antidepressants have for increased suicidality. And then you have the alpha-2 agonists like clonidine or guanfacine. So there are many more formulations of methylphenidate and amphetamines, but I just selected a few pretty popular ones. So here are some brand names for the methylphenidate products and for the amphetamine products. For substance use disorder, so alcohol withdrawal is good to know about how to treat. It's benzos or barbiturates. For alcohol use disorder, there's three options: disulfiram, naltrexone, and acamprosate. Disulfiram is an aldehyde dehydrogenase inhibitor, so it causes the buildup of acetaldehyde, which makes people feel really sick if they drink alcohol when they're on disulfiram. Naltrexone is an opioid antagonist, which diminishes some of the positive effects of alcohol. And acamprosate increases GABA, decreases glutamate activity, so it's almost like a little tiny baby alcohol itself to diminish cravings and use. Next, for opioids, opioid intoxication is definitely overdose, is good to know about how to treat. So it's naloxone products, Narcan, there's some other brand names. So you don't use oral things like naltrexone, you need IV, intramuscular, or nasal sprays to treat an opioid overdose. For withdrawal, you can use methadone, buprenorphine monoproduct, or buprenorphine/naloxone. And remember, you wait until they're already in withdrawal before you start a buprenorphine product because you can precipitate withdrawal, and you wait until they're already in a little bit of withdrawal before you start methadone so you don't overdose the patient because methadone is a full opioid. For opioid use disorder, you have the full gambit available. So you can use opioid antagonists, opioid partial agonists, or opioid full agonists, depending on your goals and what the patient wants. There are some LAI options here as well. For eating disorders, you want to treat these with therapy and nutritional rehabilitation. For anorexia, we generally don't use medications. For bulimia, fluoxetine is FDA approved for this. And for binge eating disorders, we do use SSRIs, and also lisdexamfetamine is FDA approved, because remember, stimulants can cause appetite suppression. So a patient with a history of seizures would like to start a non-controlled medication for the treatment of ADHD. Which of the following would you recommend? So the best answer is Capve. The trick would be Wellbutrin. So that is used for ADHD, but the patient has a history of seizures, so you wouldn't pick that. Which of the following is an amphetamine product? So Vyvanse is lisdexamfetamine. The other products are methylphenidate products. Which of the following medications produces diaphoresis, palpitations, and nausea when alcohol is consumed? And this is what disulfiram does. And what is the treatment for opioid overdose? That is naloxone. And what is the route of administration of Suboxone? This is sublingual. So I hope that presentation was helpful in preparing you for the NAPLEX, and best of luck.